This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, everybody, and thank you for joining us for our HealthyU Webinar Series. Today's topic is We've Got Your Back, Breaking Free from Back Pain. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will always remain anonymous. Today's presenter is Dr. Ben-Eliyahu. He's the Administrative Director of Mather's Medical Group Back and Neck Pain Center and Director of the Mather Chiropractic Collaboration Program. He has advanced certification in sports injuries and pain management. Dr. Ben-Eliyahu is widely published on spine care in peer-reviewed journals and has had many presentations on spine care at multiple conferences. He is a member of the USA Olympic Medical Society and has been selected to spend a month at the USA Olympic Training Center treating Olympic and USA elite athletes. Dr. Ben-Eliyahu was in a private chiropractic practice for more than 39 years where he directed an integrative, multidisciplinary spine and musculoskeletal practice. Dr. Ben, I will pull up your PowerPoint and then we can get started.
Okay, thank you, Jonathan. Okay, good afternoon, everyone, and thank you for attending. Today we're going to go over understanding some concepts about back and neck pain and some practical tips and strategies for relief that you can do at home, and then what to do if that's not working and who you can go see, and also a little bit about our program at the hospital. Next slide. So a little bit about Mather Hospital. If none of you have ever been to the hospital, we're part of the Northwell system. We have a 5-star rating from Medicare. We're a magnet hospital, which is a very prestigious award given to very few hospitals in the country. There's approximately 6,000 hospitals across the country, and magnet status is for excellent nursing care, compassionate care, low infection rate, and great outcomes. I'd say probably, I think the number is less than 500, which is less than 10% of the total hospitals in the United States. Leapfrog, if some of you have seen that on Newsday and on the news, that's a organization that actually rates hospitals again for patient safety. Mather is one of the few on Long Island that's had, I think now 20 A's. And then Health Grades, Lantern Awards, and the Golden Beacon Award for our top critical care. So excellent hospital with excellent accolades and excellent outcomes. Next. So a little bit about back pain. So 85% of everybody will have a back problem at some point in their lives. 1/3, 31 million Americans are currently experiencing pain right now in their lower back, and 25% new people will experience back pain every year. Well, back pain is the single leading cause of global disability for the last 3 decades with no signs of slowing down. The amount of expenditures for back pain has been growing exponentially. Probably about 25 years ago, the number is probably $40–50 billion. It's now over 600 billion. And that number just seems to keep growing. And unfortunately, despite that number rising exponentially, we have not seen a major change in the outcomes of people who are experiencing chronic back pain. It's the #1 source of chronic pain in the United States. And probably one of the most important factors is the rate of recurrence. So if you had an episode of back pain or neck pain, probably it's upwards of 60 to 70% within 1 year, you would have a recurrent episode, and 80% within 2 years. That's pretty significant. And the reason why is because there are problems that are not being looked at. Probably just the tip of the iceberg is being treated. So if you have pain and you only treat it with anti-inflammatories like Advil or Aleve and some ice, and you don't do anything to fix what got you there in the first place, history is just going to repeat itself. So the rate of recurrence decreases when one pays attention to risk factors and then also mitigates them, and as well as mitigating any medical comorbidities that you didn't know you had. Next slide. So today we're going to talk about some causes of back pain, what you can do to prevent back and neck pain, what are the risk factors that I just spoke about that help contribute towards recurrence, the high recurrence rate of back pain, what you can do to help yourself, and then what you should do if the pain just doesn't get better and you've tried everything and you're getting worse or it's just not improving. Next slide. So here's some typical causes. The picture clearly shows that that person's about to fall and hurt himself, and this kind of an injury, which it's not uncommon to happen in grocery stores on a slippery floor or even outside during winter with ice on the ground and black ice, typically can cause hip injuries, neck injuries, and back injuries. But sports injuries like pickleball injuries have become really popular now. Car accidents, work-related injuries, being overweight, anxiety and fear. We're going to talk about that a little bit. Not eating well, and then also arthritis. Next slide. So some common structural causes of back pain. Everybody's heard of sciatica, but sciatica means just leg pain. So you can see in this picture, the red highlighted shaded area on that person's leg. That's where the distribution of the sciatic nerve goes. So sciatica just means leg pain. So if you go to your doctor and you tell him, hey man, I'm having some pain down my leg, it's numb, it's achy, and he says, well, you have sciatica. Well, pretty much he just parroted what you just told him. That's kind of like a general diagnosis. Something has to be causing the sciatica. So typically it's a pinched nerve, and typically from a pinched nerve like a herniated disc. So if you look next to the picture of the lower legs, there's a crosscut, the top picture where it says bulging disc. That's a disc that's cut through. If you look at it from the bottom, the one underneath that one, it's a side view, and you can see the vertebrae, which are the yellowish square blocks. And then in between, there's a pad called a disc. If that disc kind of moves out, like you can see in the upper picture, it gets very close to the yellow nerve and it pinches the nerve and irritates the nerve, and that can cause the pain to refer down the leg. A disc, which is that pad that I just described, is very much like a jelly donut. And you can see the picture of the jelly donut on the bottom left. The disc has two parts, the inner jelly and the outer dough. Actually, anatomically, it's called the nucleus and the annulus. But the jelly can move from the middle through a tear in the dough and then actually pinch and irritate the nerve, which is then what causes the sciatica. So common structural causes, that's a really common one. Herniated disc or bulging disc pinching the nerve. Fractures, not so common. Spinal stenosis, very common due to arthritis in older age population groups. And then if you look at the MRIs, and today's purpose is not to teach you how to read MRIs, but you can kind of see the label pointing at the things that are really common that we see. The normal disc, nice and fat and white, meaning plenty of water. The degenerative disc, the bulging degenerative disc, sometimes they cause symptoms, sometimes they don't. But a herniated disc on the bottom, you can see it's pointing to that little white bubble sticking out into the white canal area. That's typically symptomatic. Next slide. Common structural problems in the neck, very similar. Herniated discs, bulging discs, spinal stenosis. The picture on the left shows you a normal disc on the top right picture versus the bottom picture, normal versus herniated. You can see that the gray stuff is kind of moving into where the white would be. And then on the picture on your right with the red circle, that's pointing to a white area in the spinal cord. That's called myelomalacia. That's very uncommon, but one that when that happens, that is a surgical case. That white inside the spinal cord is due to severe spinal stenosis, compression of the spinal cord, and that has to be surgically decompressed. Fortunately, that's probably like 1 in 50,000 to 100,000, so it's not something we see very routinely, but in my career, I've seen it plenty, and that actually can cause a lot of weakness, sometimes even paralysis, and needs to be decompressed. Otherwise, it ends in permanent impairment of weakness and numbness and a lot of other difficulties. So those are not common. The most common things that you would see is either a joint problem, a herniated disc or bulging disc, and pinched nerves. Next slide. Other reasons that are probably equally as common, you can see the word facet joint. Those red circles are pointing to the joints of the lower back. Those are called facet joints. There are 5 facets on each side of the lower back. We're looking at a lumbar spine area. And then you can see in the picture right next to it, where the arthritis is kind of illustrated, it looks like that joint is very narrowed. So the facets causes mechanical low back pain because those joints are irritated and sends a signal to the brain that, hey, we got inflammation, our joint's just not working right, and that causes back pain. And most typically, this kind of back pain is usually axial, meaning it's in the lower back area, maybe a little bit in the buttock, maybe a little bit into the thigh, but never usually down to the calf or foot. It also results in muscles becoming extremely tight, muscle spasm, or getting very knotted up. Those are called trigger points. So muscle knots are trigger points. You can see the picture next to the square that says back muscle knots. Those are little muscles that just knot up. They're actually pain producing, and they can not only just cause pain locally to where they knot up, but they can also cause referred pain. So the diagnosis of sciatica can be from a herniated disc from a pinched nerve in the lower back, but you can get leg pain like that picture on the bottom shows in that red stippled area, that a knot or just a plain old trigger point can cause referred pain into the leg too. So making a diagnosis of sciatica is pretty general and non-specific, and a really good spine clinician knows how to differentiate the pain generator. That's the key to success in taking care of any spine problem, is knowing what the exact pain generator is. I just showed you 6 pain generators that can all cause issues, but if you don't know how to tell the difference and how to point the patient in the right direction to what to take care of, the patient's not going to get better. And then lastly, the sacroiliac joint, that last bottom picture on the bottom left, that's the joint inside your pelvis. There's one on each side, and that can become dysfunctional. Probably underdiagnosed 30% of the time. It's the diagnosis in low back pain cases, but many people don't know how to diagnose it. And obviously, if you don't know how to diagnose it, you're not getting the patient to the right person to treat it. So sacroiliac joint pain can also cause back pain, typically worse when you're sitting, typically can cause pain in the lower back, usually right in the lower back area where that bump is in your lower back, just above your buttocks. And it can cause pain into the butt and into the thigh as well. Next slide. So let's talk about some risk factors for spine pain. Well, one big one is psychological distress. Think about if someone has chronic back pain for a very long time. They become depressed over it. They can't do the things they love to do. Maybe they can't work. Maybe they can't play tennis or golf. Maybe they can't garden anymore, have fun with their grandkids or their kids. So that can lead to anxiety and then eventually depression. And that becomes a vicious cycle, because now the more depressed you are, the more you want to do nothing. Just want to lay on the couch and you just want to do nothing, watch TV. And then, of course, what happens then is you tend to just eat, not exercise. You're not active. The more weight you gain, more pain you have because you're inactive, and then the more inactivity, the more atrophy. So you can see the cycle there. So psychological distress, anxiety, and depression is a big factor that needs to be corrected. Poor posture, another one. We'll talk about posture in a little bit. Smoking, considered the new sitting. Actually, sitting is considered the new smoking, but smoking obviously causes constriction of the blood vessels and allows for improper healing. Obesity, being overweight, obviously puts a lot of mechanical stress. And then there are medical comorbidities that have been shown to have a high associated rate with back pain, like hypertension, diabetes, and osteoporosis. Those things need to be identified, these risk factors, because if we're not identifying these risk factors and we're not actually mitigating them or correcting them, yeah, the recurrence rate will be very high, and you'll end up having another episode in a very short period of time. Next slide. So let's go over some myths and facts. Next. So try not to look at the answer. So back and neck pain are just true due to getting old. Yeah, back pain is because you're old. Well, if you think about it, the answer is false. There are many older people, and I've seen a lot of people in my career that have tons of arthritis, but didn't have any pain where their arthritis was. So the answer here is false. The common denominator for people is healthy lifestyles. If they're old and they don't have pain, they're staying fit. They tend to be fit. They exercise. They're active. They eat a great diet. And we'll talk a lot about diet in a little bit. And they maintain good posture. So not just from getting old, it's from a lot of other lifestyle factors. Next slide. Always use heat if your neck or back hurts. True or false? Well, the word always kind of means it's false. But in this case, it is definitely false. A good rule of thumb is to always use ice in the first 48 hours after an episode or an acute episode of pain, and then switch to moist heat after 48 hours in the later stages. Now, there is no absolute in life. So for some people, ice is always good. And for some people, ice makes them worse. But I'd say for the predominance of 98% of the population, this is a pretty good steadfast rule. Ice for the first 2 days and then moist heat afterwards. So those heating pads that you have in your closet from 20 years ago that are cloth heating pads, they just heat the skin. They don't really go deep. You need to have a moist heating pad that are easily accessible from CVS, Walgreens, or online. Next slide. All right, your mental health and stress levels have no effect on your back or neck. That is false too. The mind-body connection is extremely important. It is fact. And chronic pain, as I said before, it leads to anxiety and stress and even depression, which just perpetuates back pain. So having some sort of a mechanism to actually get rid of anxiety, stress, or even mild cases of depression are things like yoga, deep breathing, meditation. Research shows that those are all extremely effective. And in some cases of moderate to severe depression, seeing a therapist actually is a huge factor. It makes a big difference. Next slide. The use of smartphones today has no effect on your neck and back pain. That's extremely false. If you've ever watched somebody looking at their phone, you can see that guy in that blue picture. His head is forward, it's looking down and putting a lot of mechanical stress in his neck area and his upper back area. In fact, so much so that if you look at the picture on the right, you can see that where it says 12 pounds, that signifies the weight of your head on average is about 12 pounds. Your neck, if it's functional and properly stabilized, can withstand that weight of your head, which is about 12 pounds on average. Move your head forward by 2 inches. So in other words, your forward posture of your head leans forward, and you've seen people who have that. That adds 20 pounds to the neck and upper back area. That means you're walking around with a 20-pound weight on your head all day long. Move it 3 inches, and now it's an extra 42 pounds. So it's an extra 30 pounds on your head. That's a lot of weight. So do you think that's going to cause some issues with the back or neck? Of course it is. So posture is extremely important, especially when you're looking at your phone or your tablet or even working on your computer. Next slide. Regarding mattresses, there's another myth. Firm, extra firm, best for your back. True or false? False. A mattress that is too firm puts excessive pressure on your hips, your spine, and your shoulders because there's no give. It doesn't allow your spine to actually become aligned. So, but conversely, a mattress that is too soft will allow sagging and equally puts stress on your spine and neck. So you can see the pictures there. The one that's too soft, notice how it's sagging. It allows that spine by the white stippled line you see to be kind of like a C curve downwards towards the sagging mattress. A mattress that's too hard, conversely, you can see that the spine looks like it's a C curve in the opposite direction, putting excessive stress on the spine. But then when you have a mattress that is medium firm, which is what I recommend, you can see that the spine is perfectly straight. So the best way to do this is when you decide it's time to get a new mattress, go with somebody, have them look at you while you lay on your side, and make sure that that imaginary line looks straight. Your hips give in a little bit, your shoulders give in a little bit, but the back looks straight right from the tip of your tailbone right through to your neck area. That's a good rule of thumb. Next slide. The people who are blue-collar workers that do heavy physical labor are the ones that really only get back pain. Obviously, that's false. People who sit a lot are at equal risk to that blue-collar person. So there is no direction for this. Anybody who has different risk factors is putting themselves at risk for back pain. Like I said before, sitting is considered the new smoking. In fact, when we were going through the pandemic and there was nobody outside, everybody worked from home, or if you didn't work from home, you were watching TV all day long, you sat all day, there was a large spike in the people who had back issues. And that's because they were sitting so much. So sitting is not good for your spine. In fact, so much so that sitting puts about a 6-fold increase of pressure inside the disc. So the intradiscal pressure increases by over 6-fold after you're sitting for over an hour. So what's the answer? So if you're sitting at work, you got to get up. Just get up and move. You can have a standing desk, you can have a good ergonomic chair, and taking frequent breaks are really important. It's also important to make sure that you're lifting properly. But yes, heavy physical laborers are not the only people that get back pain. Next slide. Bed rest is best for back pain. So you have an episode of back pain, just go to bed. So probably okay for a day, but movement is medicine. So if you're miserable and you're a 10 out of 10 and you can't move, okay, if you have to go to bed and ice it for a day or so, that's fine. But the longer you stay in bed, the more you promote back pain because you allow those muscles to atrophy. Atrophy means waste away. Your spine has a distinct need for strong core stability musculature. If it's not there and it atrophies and becomes weaker, it allows your back pain to get worse. Just remember, medicine is exercise when it comes to the spine. Movement, and it doesn't have to be crazy exercise. It could just be simply getting in a pool and moving in a pool, swimming, just walking, great exercise. A little bit more careful when it comes to cycling, because remember I said sitting can increase back pain. So if you're on a bike, you have to be really careful that you're not leaning forward and sitting too long. Recumbent bikes, that's another story. Those are great because you're kind of recumbent sitting and you're leaning back and your knees are bent. But cycling is not on the top of my list from a spine perspective. Great aerobic exercise for people without issues with their back. But I would put swimming, ellipticals, and walking at the top of the list. Next slide. Again, if your back hurts, don't exercise. So that's it's counterintuitive. You think if your back's a mess, you don't want to exercise. But the bottom line is when you don't exercise, like I said before, muscles atrophy and decrease your spinal support. Walking, cycling, and swimming are good. Cycling, especially if you're in a recumbent position. So the picture I like to show patients is their cross-cut of their MRI picture of their spine. Notice where it says normal. If you look down towards the muscles, the black circles underneath the word normal towards the back of the back, it kind of looks like a piece of filet mignon, nice and thick and very little white stuff in there. That's normal thick muscle. When it goes to mild, you can notice that that muscle is starting to atrophy and you see white stuff. That's called fatty infiltration. And as you go from moderate to severe, you can hardly see any muscle. That's someone who's had a chronic back problem so bad that they never exercised, their muscles atrophied, and now that area where the muscle used to be has been replaced by fat. You think this person is going to have chronic back pain or recurrent episodes of back pain? Of course they are. So exercising is critical. And doing it properly is critical. And we'll talk a little bit that in a second. Next slide. And what you eat has no bearing on your back. True or false? You obviously know the answer to this is false. A healthy diet is extremely important. Eating an anti-inflammatory diet that is low in sugar, low in processed fats can decrease inflammation and maintain a healthy weight and BMI. So for example, a diet that I recommend to patients all the time, and at the Back and Neck Pain Center, we always talk about this with patients, is the Mediterranean diet. If you've never heard of it, you should Google it and learn about it, because not only is it effective at decreasing inflammation in your spine and regular joints, it also is great for cardiovascular purposes, and it also helps you maintain a healthy weight, and you actually lose weight on that diet. Excellent, excellent diet. Everybody should be practicing that. Next slide. Smoking, you know the answer to this. Smoking has a big effect on the neck and back because of the nicotine. It vasoconstricts, makes all the blood vessels very narrow, so it decreases blood supply, which obviously adversely affects healing and regeneration of cells, can actually promote inflammation and decrease immunity. In fact, so much so that a study published not too long ago showed that there was a distinct gradient in relationship between back pain and smoking. So if you're a chronic smoker, you need to stop, because your back pain, that's one of the perpetuating factors. In people who get herniated discs or end up having to have surgery, that is now a criteria for surgeons. If you're a smoker, they won't operate on you. So just like high BMI, being very, very overweight, smoking is now another reason why surgeons won't touch you. So if you're a smoker, you got to learn how to stop. Next slide. So lifestyle tips, let's just review these quickly. We've kind of touched on them. Lifting and bending correctly. I kind of went over sleeping well, the best position to sleep in, good posture while you're sitting and standing. Don't sit too long, get up and move and stretch. Your shoes, they matter too. So if you're walking, obviously you should wear running shoes. If you have flat feet, you should see someone and talk to them about potentially wearing a pair of orthotics. Because if you have very flat feet, that will affect your kinetic structure mechanically from your feet all the way up to your hips, knees, and back. So it's important to make sure that if you have flat feet, that you're wearing proper inserts. Stay active and exercise, don't smoke, manage your stress. We talked about you can do yoga, you can do Tai Chi, you can do deep breathing, meditation. Stay hydrated. Everybody should be drinking 6 to 8 glasses of water a day. And then pay attention to warning signs like pain that's not going away. And those warning signs can be simply, you notice that you're losing bowel bladder function, your gait's becoming very wobbly, your hands are becoming very incoordinate, you're dropping things, you have numbness in your saddle. Those are important things to think about if you do develop. Next slide. So proper bending and lifting, I've mentioned that before. You can notice the guy on the left, he's bending where? From his back. So his back is curved. But most importantly, look where the weight is compared to his shoulders. He's moved that weight over the center of his gravity, way over the middle. So now the only thing that's going to help him lift that weight is his back. So how do you think back injuries occur? When you're using only your back muscles. One of the strongest muscles in your body are your legs. So notice how the guy on the right side keeps his head up so he doesn't hurt his neck, keeps his back straight, but he's bending at his knees and he propels upwards after he lifts the weight. And I would recommend another picture here. Actually bring the weight close to your chest as you pick it up, and then use your legs to lift the weight up, not your back. Lifting and twisting are some of the biggest reasons that I used to see how people usually hurt themselves. They bent over, forced the center of gravity over their spine, and then they twisted and rotated, which actually allowed that disc to get injured. And lifting and twisting are some of the major reasons, it's called torsion, that actually injures the disc. Next slide. Sleeping posture, we talked about it. So if you look at the bottom picture, we talked about the correct sleeping position. Same thing goes for the neck. So a lot of people use 2 pillows. Some people use no pillows. In order for your pillow to be, and I don't care what mattress you use, I don't care what pillow you use, as long as it's comfortable and you like it, the criteria is that correct sleeping position that I showed you before, that straight line, your neck and your spine are straight. Notice how the hips and shoulders give into that medium firm mattress. I don't care what mattress you're sleeping on. Same thing goes for pillows. Whatever pillow you like the best, as long as you look like the pillow picture that says just right, your neck is in line with your spine, you could use a purple pillow, you can use a foam pillow, you can use it doesn't matter to me. As long as it's comfortable, you like it, and as long as someone that's with you is looking at you on a profile view to make sure that that's what you look like. Same thing goes for your back. If you sleep on your back, same thing, has to be good alignment. Next slide. Posture, we talked about this. Forward head posture increases the amount of weight on your upper back, but the same thing goes for your spine. You always heard your parents tell you to stand up straight, sit up straight. Well, they were right. If you don't sit up straight and you slouch, you're putting tremendous mechanical loads on your spine, on those facet joints that I talked about, and that's only going to result over time in jamming of those joints, and then pain signals going to your brain, and then the muscles becoming weaker because they're trying hard to fix it and they can't, and it just perpetuates back pain. So posture is extremely important. Next. Sitting, we talked about how it's new smoking. So notice that the guy sitting in that green picture, how his back is almost perpendicular to his thighs, and his legs, his calves are almost perpendicular to his thighs. So his calves, his thighs, and his spine are all perpendicular. One thing that I would add here is if you do sit a lot and you're on your computer or you're working, go find a box or a stool and put it under your feet. Because what that does is that forces you to be back up against your chair to maintain erect posture. So sitting makes a big difference. So make sure that you are paying attention and not slouching at your chair. If you're working on your computer, make sure you bring up the monitor so it's eye height. You just put a box or a couple of books underneath the monitor and bring it up so that you're not looking down, which strains your neck. Next slide. We talked about the feet. Here's a picture of an insert. I mean, you don't have to spend tons of money to get orthotics, but look at the picture with the green arrow on the top right. See how that person's foot is rotating inwards? That's called pronation. If you look at the left picture, notice how that person's foot on the bottom left is pronating and how it affects the whole kinetic structure from the knees to the pelvis and hips to the spine. And then once you put inserts in, how it actually helps maintain good posture and good mechanical alignment. So having flat feet or having pronated feet can actually be one of the causes for perpetual back pain. And you can get them online. The only thing I would recommend is if you're buying universal ones, that they have a hard plastic bottom and not the soft ones, like the Dr. Scholl ones that are just soft. They'll just smush the minute you put your weight on it. So it has to have a firm bottom underneath the sole. Next slide. And all you do is you put this in your sneaker or shoe, take out the insert that's in there and replace it with the full insert that you just bought. Next slide. Lack of exercise, we've talked about that. If you're not exercising, you're going to perpetuate back problems because those muscles will just atrophy. So exercise is obviously medicine for your spine. I've said that a couple of times, but it's also good for your head. So if you're having some anxiety issues or depression, mild depression, exercise is extremely good for that as well. And obviously it has aerobic effects and it's extremely helpful for your cardiovascular system. So can't talk enough about exercise. Next slide. So what are some of the exercises you can do? Well, we talked about a little bit about this aerobically. You can do walking, and walking is the easiest thing. Just put on a good pair of running shoes. If summertime, you've got access to a pool, swimming, being in water is great exercise. But at home, just doing some simple core stability exercises. Now, some of the things that you're seeing in the picture here may not be hard, may be harder for you to do, like the planks, but certainly the dead bugs, you can lay on your bed and just raise one arm up and the opposite leg. You can do pelvic tilts. These are all things that are easily accessible on the internet, and the more you do, the better. Next slide. So here's a classical picture showing the role of obesity in poor nutrition. 42% of adults in America aged over 20 are classified as obese. That's a problem because it puts tremendous amount of stress on the spine, and it's a perpetuating risk factor for chronic low back pain. And it doesn't take rocket science to understand why. So if you have a pendulous abdomen, your spine is going to compensate so you don't fall forward by leaning backwards. And that puts tremendous mechanical stress on the joints of the spine and the discs of the spine. So losing weight, eating properly, and lowering your BMI obviously is good for your cardiovascular system and your heart, but it's also obviously extremely important for your knees and hips as well as your spine. Next slide. Diet and nutrition. So take a look at this picture. And since we're not live, I can't ask you which one you think is best for you. But if you look at the picture on the left and you look at the picture on the right, I'm pretty sure most people would by default know that the picture on the right is the one that's the most healthy. So look at all the different colors there. Eating the rainbow is the key. The oranges, the reds, the greens, those are all foods that are high in antioxidants and high in anti-inflammatory chemicals. So the more you eat that type of a diet, which is a Mediterranean diet, and don't get me wrong, I'm not saying you shouldn't have cheese. I'm not saying you shouldn't have the stuff that you see on the left once in a while, but I know people who that is their lifestyle diet. They eat that every day in and day out, 3 square meals a day. And that's what causes obesity. That's what causes inflammation in your arteries. And that's what causes inflammation in your joints of your knees and hips and spine. So obviously switching to an anti-inflammatory diet. I'm not saying you need to switch to a plant food or become vegan. Not saying that at all. But I am saying that eating a predominance of what you see on the right side throughout the day makes you a much healthier person and increases your longevity and decreases pain and inflammation. Next slide. So here's the anti-inflammatory diet. It's called a Mediterranean diet. You can see the pyramid, all natural, whole grains, beans, meats and sweets, very tippy top of that pyramid, which means once in a while. But most Americans flip-flop this, and it's mostly what you see at the top of the pyramid. That's the base of the pyramid. And obviously that's why so many Americans are obese today. So eat foods that are pro-inflammatory? No. Eat foods that are anti-inflammatory, omega-3 fatty acids, fruits and vegetables, whole grains, add herbs and spices, use more ginger and turmeric in your foods and sage, drink green tea, stay away from saturated fats. Everybody likes red meat. Well, not everybody, but a lot of people like red meat. So is it okay to have that periodically? Of course. But also maybe don't use corn oil or safflower oil, switch to using extra virgin olive oil, much healthier. And then stay away from simple carbohydrates and sugar because that's extremely bad for your joints and your heart. Next slide. Anxiety and stress, we talked about that. The cycle of anxiety and stress can perpetuate back pain by A, the more stressed you are, the more muscle tightness you have. The more muscle tightness, the more it yanks on those joints, decreases your range of motion. Eventually, over a long period of time, because the muscles are tight all the time, it squeezes the blood vessels, so very little blood flow gets there. Now the muscles start to atrophy, the joints lose their strength. So you can see the vicious cycle that I'm talking about. So implementing something in your life that can actually help reduce anxiety and stress is extremely important. Next slide. So yoga, Tai Chi, deep breathing, meditation, those are all things that work and the research has shown are extremely effective. So assuming you do all this and my pain isn't going away, what should you do? Who should I go see? Next slide. Just a little bit about our center. This is just an infographic about the Back and Neck Pain Center. It's a multidisciplinary spine center that works on a premise of a pyramid and a step ladder approach to pain. So we always start with the most conservative care first, and that could be a chiropractor or a physical therapist. If that's not helping, then we go up the ladder and up the steps to a neurologist or a pain management physician. And notice at the very tip of the pyramid, it's a spine surgeon. I'd say in our program over the last decade, less than 3% of our patients ever had surgery. 78% respond to physical therapy. An additional 20% respond to injections that were needed on top of that. And then lastly, surgery. Next slide. So we work on the latest research. That's how we implement our care. We have multidisciplinary care teams, which means we have on our team pain management physicians, spine surgeons, physical therapists, even chiropractors. And it's navigated and your care is coordinated by a nurse practitioner. We look for and we work hard to identify those risk factors that we talked about that promote recurrent episodes. We don't use high-risk pain medications because they don't do anything to fix the problem. They just create addiction. And I'm not saying that opioids are bad. They're good in a post-surgical scenario. They're good, if someone has a 10 out of 10 pain for the first few days, but after that, they do nothing but promote addiction and don't fix the root cause of the problem. Root cause correction and rehabilitation is the key to happiness when it comes to a chronic spine problem. So our center focuses on identifying the pain generators and identifying recurrent risk factors so that we can make sure that perpetuation and chronicity doesn't happen. Next slide. That's our main nurse practitioner. Pretty much she just does we spend about an hour with our patients, really we're like detectives. We look at all prior records, we get any new imaging we need, we coordinate first appointment, and then we send you and set you up with whatever you need. But here's where we're really different. So we have weekly meetings with different specialties, and it ranges from surgeons to pain management physicians to physical therapists to chiropractors. We all sit down, look at every new patient we saw, and we all come to a consensus based on what we know, what is the best pathway for that person. So you're getting 6 opinions after just one visit. So you don't have to go to 6 different places now. It's just one place, 6 opinions, and then we set the ball in motion. Next slide. So this is just our spine care approach. Identify the pain generator. And that's the most important thing. I showed you there's about 10 different pain generators. If you don't know which is the one causing the pain and you just try and buckshot it, well, you're wasting time. And the more time you waste, the more chronic the problem becomes, the more atrophy there is in the muscles, and then eventually anxiety and depression. So doing this all promptly is important, and putting the pieces of the puzzle together. Because typically in my experience, in our center's experience, there's never usually just one pain generator. Especially in chronic back pain, there's usually 2 or 3. So you have to identify all, and you have to actually target all of them. If not, the person's going to be left with chronic pain. Mitigate the risk and recurrence factors, and then improve that person's function by getting them back to doing the things they love to do in life. Next slide. By the way, as we're getting close to the end here, you'll notice if you hover your cursor on the bottom, there's a Q&A area. You can type in some questions. Happy to take any questions from you in the end. So what we talked about, the importance of the mind-body aspect of pain. We also talked about the role of diet being and what you eat in pain. So we actually spend a lot of time, our nurse practitioners do, teaching this to you. We'll teach you how to do mind-body exercises like deep breathing, meditation, even chair yoga. We have resources where we can send you in the hospital to some of our providers that do these type of things. And we also have registered dietitians that, if you're interested, can actually sit down with you and teach you what to buy, how to cook, what to eat, and how to implement the Mediterranean diet in your lifestyle. Because these are both extremely important. Diet and your mind are extremely important in helping your back problem, especially chronic back problems. Next slide. So we talked about multidisciplinary care team 20, 25 years ago. Pretty much there were probably about 50 providers that treated back pain, and pretty much everybody practiced in a silo. So picture on a farm silos, meaning none of those silos communicated with each other. Now picture taking those same 3 or 4 silos and actually pushing them all together and moving the walls inside of them out. So now you have one big silo. So that's what a multidisciplinary care team is about. It's team-based care as opposed to silo care. Silo-based care means everybody did their thing and kept treating the person, never communicated with another specialty. And our program, and I started this program, it was all about the sandbox. I wanted to work with providers who knew how to play in the sandbox well, because whether we like it or not, and whether we think our discipline is the best out of all, it really is not the case. Everybody has limitations, everybody can do so much, and everybody has a role to play. So we practice team-based care, and that includes all the specialties that you see on the slide. So we put together a team of providers, if your problem isn't going away and you have chronic issues, of who's the best one, who are the best ones, which team is the best for you personally. Next slide. So just some brief stuff. I'm sure you've been to some of these providers, but I'm just going to briefly go over some of them. So chiropractic care, I'm not sure how many people have been to chiropractors. I am trained as a chiropractor. Next slide. Practiced for 39 years, was a team chiropractor for the U.S. Olympic team at the U.S. Olympic Training Center, where everybody there had to check their egos at the door, and that was an orthopedic surgeon, physical therapist, chiropractor, massage therapist, primary care physician, and we all treated the U.S. athletes together as a team to get them back on the playing field. So for those of you who aren't aware, have never been to a chiropractor, chiropractors today have come and are very different than 25 years ago. The scope of practice for chiropractors is pretty much musculoskeletal. We don't prescribe medicine, but we use imaging. We make recommendations of diet and exercise, and we do different types of treatment, which I'll go over in a second. And if 20 years ago you had asked the AMA, should I go to a chiropractor? 25 years ago, the answer would have been resoundingly no. Probably even more than that, maybe 35, 40 years ago when I first started, because no, they'll harm you. But it's been a 180. There's been so much random controlled trial research now that pretty much all the societies, the American Medical Association, the FDA, the CDC, the Joint Commission, American College of Physicians, have all said that chiropractic care manipulation is a first-line approach for uncomplicated low back pain. And the VA, which is the Veterans Association hospitals, there are over 100 hospitals, VA hospitals, that now have chiropractors that they've hired on staff. Next slide. And here's just a picture of some things that chiropractors do. So joint manipulation, like that top picture on the left, the back cracking thing. By the way, the cracking of the back, nothing's cracking. It's just gas being released from the joint. Not good for everybody. Probably in my practice, I only did it half the time. I used other tools like exercise and different types of tables. That clicky tool that you see up on the top, I use sometimes. Hands-on muscle work. Infrared laser therapy, rehabilitative exercise, traction. Those are all things that we used. Next slide. And I relied on this particular table the most. It was called a Cox table, which the table actually helps to decrease disc pressure and move the joints manually, both in the lower back and the top right, the neck. I actually published a paper probably 20-something years ago looking at herniated discs. I got the MRI places to repeat the MRI for me. And if you look at before treatment, you can see that that bubble sticking out in the red circle, that was a herniated disc. And then about 4 months later, it was gone. So flexion distraction with this Cox table actually it decreases intradiscal pressure, and it's very effective at conservatively reducing disc herniations without the need for surgery. Next slide. So our hospital's PT department, very unique. I'm going to go over that real quickly. Besides the typical, next slide, besides the typical postural assessments, strength testing, and range of motion stuff that most physical therapists do, next slide, we are one of few physical therapists that use the McKenzie method. The McKenzie method is, you have to be certified in it. It's like 4 weekends and lots of hours. You have to take a test. but it isolates the best movement that reduces the pain. So if you have sciatica, pain down your leg, let's say from a herniated disc, and you notice that when you go into extension and you lean backwards, it relieves that sciatic pain. That means that you're extension biased. That's your directional preference. The direction of extension reduces your leg pain and centralizes the pain. It may increase your back pain, but the leg pain actually goes better. So we want to teach you what to do in extension so that you can do it at home and both in the clinic. And equally important that if there's ever a relapse, you know what to do at home. That's called the McKenzie method. Next slide. So our hospital is one of few that have multiple McKenzie therapists. You could see on the picture on the right, the patient in the blue shirt, that person's going up into extension because it's relieving their buttock and leg pain. And basically what's happening is, as they're going into extension, it's actually pushing the disc back into the middle away from where it's pinching the nerve. That process is called centralization. It's moving the pain away from the leg to the middle of the back area, and that's actually a good prognosis. Repetitive exercises like that will actually work at helping to reduce the disc herniation without the need for surgery and even injections. Next slide. Interventional pain medicine. These are docs that do injections. Some of you may have seen them. Next slide. And some of those things include trigger point injections, epidural injections, facet injections, and there's some really new, cool procedure that our hospital does for advanced cases of spinal stenosis that work really well. Next slide. Epidurals, if you've never had one, it's an injection of cortisone right where the disc is inflaming the nerve root. I've personally had one. It works really well. Yes, you can't have them repetitively, but what they do is they help reduce your pain, which sometimes is at a very high level, and allows you then to go ahead and correct the problem by doing physical therapy like McKenzie or a chiropractor on the Cox table and core stability exercises to get your back muscle strong. Because if you were a 10 out of 10, there's no way you could do any of that. So getting an epidural helps relieve your symptoms, reduces the inflammation, and allows us to take a step backwards in that stepped approach to go back and actually work on the root cause. Next slide. Facet blocks, we talked about facet pain. Sometimes just doing a little injection of an anesthetic into the facet joint can relieve the symptoms and tell us that this is the reason for why the pain is there. So not only is it diagnostic, meaning it identifies the pain by causing relief, just like when you go to the dentist and he does a Novocaine injection prior to tooth surgery, you know that, when he injected the area where the tooth problem was, that the pain went away, you know that that area is where the tooth problem is coming from. Very similar with the facet joints, except we'll use a little cortisone as well. And then if that works twice, then we'll actually burn that sensory nerve. It's called an ablation, and that usually takes care of the pain for a long time. Next slide. New concept. We never realized this, but the bones have nerve endings. And if there is inflammation in that bone, that can actually cause chronic back pain. And we were taught in school many years ago that the bones did not have nerve endings. Turns out that was not true. Next slide. So there's an ablation therapy for that. They simply just ablate the nerve, and that nerve doesn't grow back. And I've seen some pretty miraculous things on people who've had chronic low back pain. For people who have spinal stenosis, there's a mild procedure in Vertiflex. Picture on the left is called mild, where we use a probe. These are all outpatient procedures, like 20 minutes in the surgery center. We go in there and we just kind of cut away some of the ligament that's causing the narrowing of the canal. And these are extremely good for people who have mild to moderate cases of spinal stenosis that are not good surgical candidates. And then Vertiflex is kind of like, if you can look at that top picture and you look between the bones, you can see almost like a jack that's there. It actually opens up the space because people who have spinal stenosis typically complain of leg pain. And typically leg pain that gets worse when walking. In fact, we call it a shopping cart sign because patients will often tell us, hey, when I go shopping and I lean over on the shopping cart, I actually feel better. And that's because they're opening up the spine. So that little device that you see in the spine there, that actually opens up the spine, and it's an implantable thing that takes 20 minutes to do. Next slide. Spine surgery, like I said before, less than 3% of the patients we see ever need spine surgery. Next slide. And the indications are herniated discs, people who are not getting better with physical therapy, injections, or chiropractic care, spinal stenosis. Someone has spinal cord compression, like that picture I showed you in the beginning with the white stuff in the canal. So if you look at the third picture down, you can see the red arrow pointing to the myelomalacia, that white inflammation in the spinal cord. That needs to be decompressed. Spondylolisthesis, fancy fancy medical word for slippage of the vertebrae. On the very bottom picture, that vertebrae has slipped almost 50% off its base. Typically, that's unstable. That needs to be fused. I'm not a big fan of fusions unless it's absolutely necessary. This is definitely one of the necessities. And if you don't get a fusion and you only get partial discectomy, meaning you only take away the disc that's pushing out, history will repeat itself. So sometimes fusions are absolutely necessary. And at our hospital, we have both orthopedic spine surgeons and neurosurgeons that are excellent that perform spine surgery that we work with. Next slide. So in conclusion, I've given you a lot of food for thought, a lot of things to do at home, a lot of things to draw on if you do have a problem, changing your diet, working on your posture, how to sleep better, how to stand better, how to sit better, how to get up, how to eat better. These are all really important lifestyle changes that can help reduce your pain and help prevent it. Exercise is medicine. Remember, sitting is the new smoking. Sit less, move more. Work on your posture. Eat, sit properly, eat better. Adopt a Mediterranean style diet. If you have a lot of stress in your life, learn how to reduce that stress by doing deep breathing exercises, meditation, body scan meditation. And if it's not getting better, call us to the Back and Neck Pain Center. We're happy to help. Our numbers, I think, is on the next page, Jonathan. Yeah. So take a picture of this with your phone, and I will stick around. Go ahead and type in any questions you might have on the Q&A area on the bottom.
Yeah, we'll give it a few moments to see if anybody has anything.
Okay, looks like there are no questions, but take down that number. If you have any questions or need anything addressed, feel free to call it. We'll be happy to see you and happy to go over everything I just talked about. Well, I hope you learned a lot today, and everybody have a great afternoon. And thank you, Jonathan, for managing this.
Thank you so much, Dr. Ben. Everybody have a great day.